I would like to thank the Brain Tumor Foundation for inviting me to speak today. It is truly an honor. For those of you who do not know me, my name is Shayna Zelcer, and I am a pediatric oncologist at the Children's Hospital in London, Ontario. I specialize in the area of pediatric neuro-oncology or brain tumors, and I also work in our survivor clinic, or what we refer to as aftercare. And I've had the privilege of caring for many survivors of childhood brain tumors who are currently children, teenagers, and adults. I'm excited to speak to you today about pediatric brain tumor survivorship and the challenges and opportunities from a clinician's perspective. I hope that the information that I impart to you will empower you from a patient, family member, or caregiver perspective. I have nothing to disclose other than the patients who I will be speaking of gave me permission to use their name and to disclose the medical information that I will be sharing. A big thank you to them and their families. I hope by the end of this lecture, you will all be able to learn the definition of a late effect and to gain an appreciation of childhood brain tumor survivors in terms of their demographics, as well as the unique medical and psychosocial issues that they face. I also hope to impart the important role of a multidisciplinary care team in the care of any childhood cancer survivor. And lastly, I hope you will have a taste or appreciation of the direction of the research in the area and how it affects our current decision making and therapeutic choices for our survivors, but also for our patients currently undergoing treatment. We are proud as a community caring for childhood cancer that we have come so far, from a survival rate of 10% in the 1950s to an overall survival rate of 83% for those diagnosed with a childhood malignancy currently. Great advances have been made in outcomes for those with brain tumors, although as a group their mortality rates are the highest of childhood malignancies. This is because for certain subsets of tumors, such as high-grade gliomas, prognosis is still poor. However, for other pediatric brain tumors, particularly the most common malignant brain tumor, medulloblastoma, significant gains have been made. As a result of our improved outcomes, we have a growing cohort within our population of adolescents and adults who are childhood cancer survivors. It is estimated that in the United States, 1 in 500 young adults less than 30 years are childhood cancer survivors. This poses an important healthcare issue as these individuals have unique late effects of their cancer and its treatment and thus have specialized needs. Treatment of cancer in the child can result in long-term effects secondary to multiple factors. A child can experience a complication of any surgery they undergo. For example, those children that presently have surgery to remove a tumor from the back of the brain, specifically within an area called the cerebellum, are at risk for developing posterior fossa syndrome, which can result in long-term impairment of speech or swallowing or gait and balance. Furthermore, the tumor itself can cause long-term damage. For example, a tumor along the optic nerve can result in long-term impairment of vision. The agents we use to treat cancer, such as chemotherapy or radiation, can also cause a range of long-term effects. Furthermore, children can be very susceptible to these side effects, as their bodies are in the midst of developing and maturing. And lastly, there are a myriad of unique sensitivities in each child. For example, there are certain genetic variations that can make a child more or less susceptible to certain outcomes. The definition of a late effect is any side effect in a childhood cancer survivor that persists or develops greater than 5 years from cancer diagnosis. Late effects of cancer can include effects on growth and development, effects on organ and tissue function, as well as effects psychologically, including survivors' emotions, their cognition and memory, as well as their social and psychological adjustment once they re-enter back into the regular environment and routine. Lastly, some cancer therapy in itself can cause a secondary cancer, as our armamentarium to treat cancer, i.e. chemotherapy and radiation therapy, can lead to damage to the cell's genetic code, or DNA, leading to eventual changes that cause a new malignancy. An important concept for us to understand is that the risk of these late effects increases over time, well into when a survivor meets adulthood. To understand this concept, I'd like to refer to a landmark study published by Dr. Kevin Oeffinger in 2006 in the New England Journal of Medicine. This study was derived from what I will be referring to later on in this lecture, the Childhood Cancer Survivor Study. It is a large international study from which a great deal of our knowledge and data has been formed. In this study, Dr. Oeffinger outlined the number and severity of health conditions with which childhood cancer survivors have been diagnosed. The mean age of the patients studied was 29 years, and they were an average 17 years off treatment. Approximately 60% of survivors had been diagnosed with one or more health conditions, including both minor and severe conditions. These health conditions range from hormonal imbalance, requiring a daily medication, to a more serious condition, such as a stroke. The following slide and its graphs refer to these serious health conditions. And as you can see, the risk of developing a new chronic health condition increases over time. And as survivors head into middle age and beyond, the cumulative incidence of multiple serious health conditions increases. With respect to brain tumor survivors, one can see that compared to survivors as a whole, the risk of chronic health conditions is considerable, and certainly their health outcomes are more complex and burdensome. It is this increasing risk of late effects over time that drives our emphasis for good quality ongoing healthcare and surveillance. The good news is, however, is that the rates of these severe health problems in our survivors have decreased over the decades. This is likely secondary to advancements in our treatments that have lowered the toxicity. The rates of severe health conditions of those survivors treated in the 1990s is much lower in prevalence compared to those treated in the 1980s. And those treated in the 1980s also have a lower prevalence than those treated in the 1970s, etc. We have discussed the risk of chronic health conditions in our survivors, and unfortunately, this risk also applies to their overall mortality. Compared to the general population, our brain tumor survivors are at a higher risk of death. This risk can be defined by two time periods. The first is 5 to 10 years from diagnosis, in which death from recurrence of their primary tumor is the most prevalent cause. And after 10 years from diagnosis, however, secondary cancers and organ dysfunction, such as heart disease or stroke, are the most common cause of death. This leads me to our current paradigm in pediatric oncology, in which our focus has shifted from cure at all costs, which was certainly our goal in the past where our cure rates were not very high, to cure is not enough. We need to develop new and better therapies that maximize cure but minimize toxicities in our survivors. Dr. Anna Meadows, a pediatric oncologist at the Children's Hospital Philadelphia, was the first to publish an article on childhood cancer survivorship in 1974. However, her observations and teachings were actually tucked away for a while until the 1990s, during which the field of childhood cancer survivorship expanded and research in the area started to grow, and furthermore, its importance began to be recognized. Much of what we know about childhood cancer survivorship is derived from the Childhood Cancer Survivor Study, which I alluded to earlier. The Childhood Cancer Survivor Study was started in 1994 and funded by the National Cancer Institute, or NCI. It involves 26 participating institutions. Childhood cancer survivors treated between the years of 1970 to 1986 were identified at each institution. More than 14,000 survivors were surveyed and have been followed for their long-term health outcomes. In addition, 4,000 of their siblings were recruited as comparison subjects. Due to significant changes in therapy of childhood cancer over the last 30 years, a second group of 10,000 participants treated between 1987 and 1999 were also recruited, along with 1,000 of their siblings. Thus, the Childhood Cancer Survivor Study follows 3 decades of survivors. Their methods of data collection have been a survey or questionnaire that has been completed by survivors and their siblings, as well collection of DNA through cheek swabs that the survivors have completed and sent in. The Childhood Cancer Survivor Study is ongoing, and numerous publications have resulted from this study. Of the 24,000 participants, approximately 12% of them are brain tumor survivors. There has been some worry that this population may be underrepresented in the study, and worry that some of the methods of data collection may be difficult for some brain tumor survivors. However, the Childhood Cancer Survivor Study has had an enormous impact in terms of changing and shaping our knowledge and practice. The next important milestone in survivorship care was the establishment of survivorship clinics. The first clinic was begun by Dr. Meadows again in Philadelphia in 1983. Within Canada, of the 17 childhood cancer centers, 12 have survivorship programs, and a survivorship program exists in every province. Within Ontario, the Pediatric Oncology Group of Ontario has had an integral role in the establishment of services for survivors and government advocacy for funding of resources. These clinics are multidisciplinary in their nature, and their aim is to address the medical and psychosocial needs of childhood cancer survivors and their families. Our goals within these clinics are vast. In London, Ontario, we follow our survivors across the lifespan. In other clinics, survivors are divided between pediatric and adult centers. As our childhood cancer survivors grow in age, we follow them and address the late effects that have been diagnosed, but also screen them for new and possibly emerging complications. Mixed in with this are the concurrent morbidities that we all accumulate over a lifetime and how they interact with the existing late effects in our survivors. As clinicians in this area, we are traveling through this with our survivors as new knowledge and experience accumulates as they continue to age. Currently, the survivors in the childhood cancer survivor study are middle-aged. We have yet to learn what happens over the next decade. To illustrate the issues brain tumor survivors must cope with, I've brought examples of my wonderful, amazing patients. The first is beautiful Sara. She was diagnosed at the age of 3 years with an aggressive brain tumor called a pineoblastoma. She had multiple areas of involvement in her brain. Sara underwent surgery, chemotherapy, high-dose chemotherapy and stem cell transplant, as well as radiation to her whole brain and spine. The picture on the right is of Sara in a cute pink sweater with her sister's arms around her. To the left is Sara now in a beautiful fancy dress. Sara received all this therapy when she was very young, and the young brain is very susceptible to the effects of all of this treatment, especially radiation therapy. In fact, we often attempt to avoid or delay radiation therapy in very young children and infants. Sara has dealt with a number of issues later in life, but specifically, I would like to talk about her schooling. She is currently integrated in the regular school system with specialized help and programming, but there are challenges that her and her parents, who are strong advocates, currently face, and we are certain new academic and cognitive challenges will come in the future as Sara is older and typically the cognitive demands in school and life become higher. Sara also has had issues with fatigue and sleepiness and takes some medication to help her stay alert and focused during her day at school. Sara's story is an example of the first category of late effects I would like to speak of. That is the effects upon the central nervous system. These effects can be due to surgery, chemotherapy, but also largely due to radiation therapy that they receive. These effects can include cognitive impairment, including effects on memory, attention span, executive functioning, which involves complex decision-making and problem-solving, as well as processing speed. Childhood cancer survivors can also have difficulties with socialization, and the reasons behind this are multifactorial, but they include the survivor's difficulties in understanding or reading social cues or in communication. It has been demonstrated that a decline in IQ occurs in survivors over time, and that this decline is accentuated in those who receive radiation at a younger age. Other neurologic impairments have included hearing and vision impairment, the development of a seizure disorder, the development of areas within the brain that are injured and necrosis or death of that tissue ensues. Survivors may have weakness or paralysis or spasticity of one or more of their arms or legs secondary to the tumor or surgical interventions. Survivors may have pre-existing coordination or balance issues as a result of their disease or therapy. Survivors can be at risk for chronic headaches as well as excessive fatigue. And survivors are also at risk for the development of a stroke. And furthermore, the development of blood vessel malformations in the brain, the most commonly being what we term as cavernous malformations. These effects are often dependent upon a number of factors, including the age of radiation in which the child received. The younger that the child receives radiation, the more susceptible they are to its late effects. The dose of radiation that they received, as well as the field of radiation. Either was it focal and more concentrated, or involving the whole brain and spine, or craniospinal. And as I mentioned earlier, unfortunately, the risk of these neurologic late effects increase over time, and there is no plateau. I'd like to move to the next category of late effects, and that is the development of secondary tumors or malignancies. To illustrate this, I would like to speak of Andy. Andy was diagnosed at the age of 11 years with medulloblastoma, the most common malignant brain tumor in childhood. Andy was treated for this in 1977, during which radiation techniques were less focused and dosing of radiation was much higher. Andy had a number of late effects, but specifically I'd like to speak to the secondary tumors that Andy developed as a direct result of the radiation he received. Andy developed his first tumor, called a meningioma, in 1990 and developed a second one years later. He also developed blood vessel malformations within the brain, referred to as cavernous malformations. And then he then developed a tumor within his brainstem, which he succumbed to this year at the age of 50. Pediatric brain tumor survivors are at risk of secondary cancers, both within and outside of the central nervous system. Within the central nervous system, patients are at risk of secondary brain tumors, the most common being meningiomas, which are tumors of the lining of the brain, but secondary high-grade gliomas can also occur. Outside of the central nervous system, survivors are also at risk of developing skin cancers, including basal cell carcinoma, as well as a melanoma. Furthermore, the thyroid gland is sometimes within the field of radiation and is also at risk of developing a secondary thyroid cancer. Lastly, childhood cancer survivors are at risk of secondary sarcomas or carcinomas, or tumors of the bone and soft tissue and connective tissue, all of these that were within the area of exposure to radiation. The risk of secondary neoplasms overall is approximately 10%. Thus, when following these survivors, we often take thorough histories and do a head-to-toe physical examination, searching for any signs of secondary tumors, as well as we follow surveillance guidelines to screen for those, including a thorough skin exam and periodic imaging of the brain. I'd like to move on to the next category, and to illustrate this late effect, I would like to introduce you to this lovely young girl. This is amazing Kendra, who is posing for her grade 8 grad picture. We are so grateful for how far she has come. She was diagnosed at the age of 9 in 2012 with a metastatic medulloblastoma. Kendra has had a number of late effects of her treatment, including hormonal insufficiencies. She was diagnosed with hypothyroidism and requires thyroid medication. She is also on growth hormone injections for 6 days per week, and she is on estrogen supplements for ovarian failure. All of these endocrine issues are secondary to the chemotherapy and radiation therapy she received. Kendra handles all this like a trooper and always comes to clinic with a smile on her face. Hormonal insufficiencies and disturbances are common in brain tumor survivors, particularly those who have had radiation. Growth hormone, which is produced by a gland in the brain called the pituitary gland, is particularly sensitive to the effects of radiation. The development of growth hormone deficiency is very common, and as illustrated in this graph, is related to the dose of radiation received. Pediatric brain tumor survivors can thus have a shortened adult height, which can be profound without treatment. However, other factors can contribute to the shortened height, including radiation to the spine, which stunts its growth. We often wait approximately 1 year off treatment before treating growth hormone insufficiency. There is a theoretical concern that the growth factor can induce latent tumor growth, but the evidence has shown that growth hormone treatment does not increase the risk of primary tumor relapse. There may be some correlation with secondary tumor development, although this has not been proven and hard to discern due to small numbers. Optimizing a survivor's growth not only includes growth hormone supplementation, but also optimizing nutrition, ensuring that the thyroid function is normal, and also intervening if puberty ensues early, which can occur in our survivors by providing hormones that put a temporary brake on puberty to allow optimization of growth before the survivor's bone plates fuse, which is what results at the end of puberty. And once this occurs, a child can no longer grow. Another common hormonal insufficiency is that of disorders of the thyroid gland. This can include hypo and hyperthyroidism. Furthermore, survivors are more predisposed to developing cancerous and non-cancerous nodules within the thyroid gland. Lastly, disorders of puberty and fertility can also occur. Puberty is turned on by the brain at a certain age, and survivors are at risk of this switch being turned on late or delayed, or turned on early, resulting in precocious puberty. Furthermore, the ovaries or testicles can be affected by our treatment, which can also cause delayed puberty, and some survivors require hormonal supplementation for this to ensue. Furthermore, this effect can result in early menopause in women and infertility in both women and men. And we as clinicians are currently offering those at high risk of infertility the opportunity to sperm bank or cryopreserve their eggs. Lastly, survivors are at a risk of myriad of other chronic health conditions. Late effects can include the effects on the heart, including cardiovascular disease or heart failure. Lung complications can develop, and a number of musculoskeletal complications can occur, including scoliosis of the radiated spine, underdevelopment of the muscle or bone that was radiated, including a physical deformity or discrepancy in length of both limbs, as well as painful areas in the bones, most commonly the knees, where necrosis or death of an area has occurred. Osteopenia and osteoporosis, or low bone density, can also ensue. These are some examples of the late effects that our survivors experience and that we address and screen for in our clinics. The next hero I'd like to speak about is Nicole, who was diagnosed in the year 2000 with a medulloblastoma. Her most significant issue is her balance, motor, and speech impairment that she has been left with. Nicole is a shining example of a determined young adult. In spite of the fact that she walks with a walker and requires several resources to assist her in the classroom, Nicole is pursuing a secondary education at Fanshawe College in London and is living on campus. She is truly an inspiration. Nicole is a shining example of a survivor that has accomplished a great deal in her life in spite of her disabilities. As we follow our survivors into young adulthood and the next phase during which they gain independence, we journey with them into their next set of challenges, including secondary education, employment, marriage, and all those other milestones we achieve as adults. Some survivors struggle in attaining these milestones, and we need to support them to achieve their potential. Now, after going through all of these late effects, I'd like to emphasize that it's important to put all of these findings into context. And this was best articulated by Dr. Kevin Oeffinger in 2006. Cancer is a deadly disease, and to cure it often requires fairly toxic therapy. Because children and teens have organs still in the growing stage, they are particularly vulnerable to the effects of these therapies. So it's common to see chronic health problems years after. The silver lining, however, is that cancer survivors need to realize that some of these conditions can be prevented, and many of these can be reduced in severity. So what are our next steps? So the next steps for our survivors and their families are to continue to go to survivorship clinic in order to receive specialized care and to undergo surveillance for the late effects that I've mentioned, to reestablish care with their primary care physician. Our multidisciplinary clinics provide treatment summaries and long-term follow-up guidelines to the primary care physicians in order to help facilitate them in their ongoing care of these patients. I also encourage our survivors and their families to be advocates for themselves, to ask questions, and to empower themselves with knowledge in order that they achieve their best outcomes. For our survivors, I think it's very important for them to understand what risk-based follow-up care is. So in our multi-D clinic, we monitor for a number of different things, including monitoring for the risk of the emergence of a secondary cancer. And we do surveillance for these secondary cancers and late effects. Because we have found that early diagnosis of these late effects and early intervention can lead to the best outcomes. We also talk about preventative measures, for example, avoiding or limiting tobacco use, increasing one's physical activity, and optimizing one's diet. And we counsel around these healthy preventative measures in order to decrease the late effects of decrease the risk of these late effects. And we risk-based follow-up care involves tailoring our care, our surveillance, and our monitoring according to the survivor's diagnosis and their therapy. An example of this is Cailyn. Cailyn has been my patient since 2004, and she has undergone multiple surgeries and multiple rounds of chemotherapy for her brainstem tumor. She has not received any radiation therapy. She is a brilliant grade 11 student who excels academically and plays many instruments. She does not grapple with some of the side effects that I've illustrated earlier, but she has her own set of issues, including weakness in one of her legs. When Cailyn joins us in our aftercare clinic, which will be soon, we will devise a plan based on her treatment history and chronic issues as to what our recommendations will be, and her plan will be tailored according to her past history and her specific needs. In spite of the importance of pediatric brain tumor survivors being followed by a childhood cancer survivor clinic, a recent publication by the Childhood Cancer Survivor Study has demonstrated that actually, as years ensue from diagnosis, the number of visits to a specialized cancer center for care decreases. And thus, as survivors age, and they accumulate more late effects, Unfortunately, they receive less follow-up care, and thus a larger gap ensues. This is Kristen on her class trip. Kristen was diagnosed at the age of 11 with a pineoblastoma and underwent similar therapy to Sara, but at an older age. She's about to graduate grade 12, and her parents and I need to empower her to be aware of her healthcare history and issues as she embarks onto her secondary education at the university of her choosing. I need to educate Kristen that her healthcare and surveillance needs to be lifelong. I need to empower her to be able to speak about her treatment to healthcare professionals, and to have the knowledge she needs no matter where she is as she grows and matures into adulthood. We need to ensure that Kristen does not fall off the radar and become part of the gap that I previously showed you. So where do we go from here as clinicians? Our first is we need to seize opportunities to minimize the toxicity for our treatment. And we are already beginning to do so. A very good example of that is the treatment of medulloblastoma, which is the most common malignant brain tumor in children. For those diagnosed with medulloblastoma, all patients historically received a dose of 3,600 centigrade to the whole brain and spine, with a boost to the whole back of their brain or the whole posterior fossa to a total dose of 5,400 centigrade. Currently, however, efforts have been made with ongoing research and collaborative studies that our standard of practice has now been to reduce the dose of craniospinal irradiation to 2340 centigrade to the whole brain and spine, with the high dose of 3,600 centigrade restricted to only those who are considered high risk of relapse. The delivery of whole posterior fossa irradiation has been eliminated, and now we currently only radiate the tumor bed with involved field radiation therapy. And currently we are doing further research to identify a subset of patients that can actually be treated with a dose of 1,800 centigrade to the whole brain and spine. Historically, it was believed that the brain has very little regenerative capacity and that neurologic damage cannot be easily repaired. However, recent research in the area of neuroplasticity has shown that the brain actually has more regenerative capacity than we once thought. It has been shown that exercise programs, certain cognitive training programs, referred to as CogniMed, and certain drug therapies can improve cognition, and perhaps a future approach will use a combination of all of these interventions in order to help improve outcomes for those who have received neurologic impairment from their therapy. Currently, we do try to seize opportunities for early intervention for those who have neurocognitive late effects. We perform a neuropsychologic assessment in all our survivors. We work with the school program in order to ensure that they have an optimal IEP program. We also advise our survivors to embark on regular physical activity, as it's been shown to improve cognition. There are also opportunities for our survivors to partake in the cognitive stimulation programs, such as CogMed. And we have begun to use pharmacotherapy, including psychostimulants, such as Ritalin for fatigue, to help attention and concentration. Lastly, our survivors have had the opportunity to be involved in psychosocial training groups to help them in terms of their communication and in terms of their socialization. Currently, there are guidelines established by the Children's Oncology Group in terms of how we do our screening and early intervention. We provide a treatment summary to all of our survivors, as well as to their primary care physicians and other healthcare professionals involved in their care. And there is current research into identifying subsets of patients who are at risk for a particular late effect, and thus to tailor our care even more precisely to that individual, because in fact, no two survivors and their late effects are alike. The following is the Children's Oncology Group guidelines that we currently follow in our survivorship clinic. We are actually on version 4.0, and we try and make a summary available, as I mentioned, to our survivors as well as their healthcare providers. So I'd like to summarize this talk by discussing what I see as the challenges for myself as a clinician caring for pediatric brain tumor survivors. And I'd like to categorize these challenges in terms of past, present, and future. With respect to the past, those patients who have been treated, my challenge or my goal is to optimize their healthcare outcomes. With respect to the present, using our current resources, I think important areas that we should try to achieve are further outreach to our adult healthcare providers and empowering our survivors with knowledge and the power to advocate for themselves, and also harmonization of our long-term follow-up guidelines across international groups. And with respect to the future, for those children who will be diagnosed with a brain tumor and receive treatment, of which I hope there are none, but in the case that there are, I hope that we continue research into tailoring our therapies and try to strive to minimize our toxicity. It's a tall order, but we owe it to the Saras, Andys, Nicoles, Kendras, Cailyn's, and Kristen's that we care for. Thank you.